أروان غيري. أنا senior radiology resident. أشتغل في كينج عبد العزيز Medical City في الرياض. If anyone who doesn't know the terminology, which is radiology resident, I'm basically dealing with images طول الوقت, and they look at images and write the report that you find in the system later on if you start working in the hospital. And this is exactly my job. I'm still not a board certified person, يعني. Inshallah, by at the end of this year, I'm going to be board certified. I'm going to be a general radiologist. يعني أنا 6 months into being a general radiologist. Like, or 6 months until I become a finalized version of general radiologist. طيب. Okay, we will wait another 2 minutes and then I will start. حلوين؟ طيب. ما شاء الله العدد مرة رائع. ما أدري كيف تبون جايين تحضرون يعني إن شاء الله تستفيدون كلكم يا رب. طيب. لا تنعرف المنظمين على الأكتيفيتي جد يعني شكرا جزيلا على تنظيمكم وجدا they are very professional. I like dealing with them. Unfortunately I'm not the professional person لأنه ردودي شوي ليست رائعة فأعتذر عن الشيء هذا بس I really liked how everyone interacted with me. So okay, I think it's now fair to start. حلوين؟ طيب. How to read a chest X-ray. Let's start. My outline, I'm gonna give you 4 lectures. Each lecture gonna have certain theme to it. عندنا anatomy lecture, and then we will have a 5-minute quiz. We're gonna have a black lecture called a black lecture, and then we have tubes and lines, and then white lecture. And then at the end, we're gonna have a Q&A. We might have Q&A at each session. We will see later. حلوين? My target or my disclaimer about these lectures is that my objective of these lectures is to develop a sense of gut. I want you to walk out of these lectures with a gut feeling that when you, let's say, when you are presented with an X-ray in any situation later on, you have this gut feeling that tells you there's something wrong with this image, and you don't really pass patient as being normal. If I could develop this gut feeling in one of you guys, I'm really happy. تمام? And then I want you to trust your gut and act upon it later on. حلوين? So we will start with the basics. So this is my account or my form. You can see my name, Arwa. You can add this on the pull app, Arwa AA067, so that we will have the quiz later. You don't have to do it right now. We will do it later at the end of the lecture if you want. And let's start. I'm sure everyone of you had attended an anatomy lab. So by far, I assume everyone has attended and was examined on anatomy labs. And you have seen this diagram, which is showing the ribs, the lungs, the heart, the liver, the stomach, and the spleen. Do you see my mouse, or is not that clear?
Yes, it's clear.
Yes. So when you have been presented with this, so let me translate this image to a radiological image. So these are the images that you usually see in your textbook and anatomy books. You see lungs, you see heart, you see diaphragm, you see trachea, which is the airway, and then you see the ribs. If you look, this is the rib cage. This is the outside rib, the bony structure, and then when you open it full open, you could see soft tissue structures, which are the lungs and the heart. Okay, this is what you usually see in your textbook. This is another diagram just to show you the structures that usually in the chest. So we have the trachea, we have the lungs, we have the heart between them, squeezed between them, and then we have the ribs bilaterally. Okay, simple. Underneath, we see the liver and the bowel structures. We see the liver on the right side and the stomach on the left side, and the spleen on the left side. Basic anatomy, nothing difficult about this. So what is an X-ray? I'm sure everyone has done an X-ray in their life before admitting or being admitted to the medical school. They ask you to take off everything that is metal, and then they ask you to face the square structure, this white square structure, which is the detector. You are faced towards that detector, and then we radiate you or give you the X-ray radiation from a structure behind you. So it became, the radiation came from your posterior to your anterior. Simple, simple. So it became posterior to anterior. And this is what we call the PA view, the posterior anterior chest radiograph, which is the standard of all the chest radiographs. Whenever you are seeing chest radiograph, it's usually done posterior to anterior. This is for young, fit, adult, they are okay. But what if the patient is really sick and he cannot stand being or standing up? So we do the AP view. AP, from its name, we start from anterior. Anterior means in front of the patient. The X-ray is in front of the patient, and it's go through the patient, and you see this black thing behind the patient. This is the detector. This is how we gain our image. Why am I explaining the posterior and anterior? For a purpose. I'll explain it later. So when we gain an X-ray, when you give radiation and we have a detector and we see the organs, we see it in this manner. We see black and white stuff. So what are the black and white stuff? Black is air, and whiter is usually bone and metal. Why is that? Why is things are different? Why they are in a gray spectrum? The reason for that, the X-ray usually is held up by anything that is heavy on its core. For example, metal is really heavy. If you attended chemistry class before, if you know the Z number of the tissues, if the heavier the tissue or the heavier the Z number, the more the radiation or the more whitish it's going to be on the X-ray. The lighter it is, the more it's going to be blackish. If you want to think about this, you can think about this in density or katafa. The lightest stuff will be blackish. So air is very light. Fat is very light. They always say when you want to use fat or whatever, they told you always that fat is very lighter than the muscle, because that's true. Fat is very light, and that's why it looks blackish on the X-ray or in any radiation or any modality of radiation. And then when you go from air until metal, it becomes brighter. So anything that's darker is very light. Anything is white is very heavy. Does that make sense? It makes sense. If you look at the image here, we see the lungs are very dark because they contain a lot of air. We see the heart in the middle looking very white. We see the trachea in the middle looking very white. However, we could see darkness there. Means it can contain air in them, or it can contain air. That's why it looks darker. And then we could see the bilateral bones, which looks white. Makes sense. صح? Inshallah. I told you the previous slides that we have an AP and PA view. Let's start with the most common one, the one you did in your medical school. So you have a PA where we give you the radiation from your back until the front. Why I'm teaching you this concept? Because I want you to understand. When we give the radiation from the back to the front, the heart looks normal on the X-ray. You see the gray here? This is appropriate size of the heart. So when the person who read your X-ray didn't say you have a cardiomegaly, didn't say you have a large heart, because everything was aligned and everything was good. However, if the patient is very sick, we don't have another choice of doing an X-ray. We do it anterior to posterior. We do the X-ray from his in front because he's laying on his back. What we did is that when we give the X-ray, it made the heart look bigger on the X-ray. So the heart usually looks bigger on an AP view. Let me show it to you in an example. The difference between a PA and an AP view. The posterior anterior will show a normal size organs. We see the heart looking normal. This is the shadow of the heart. We don't see the heart in details. We only see the shadow. It looks appropriate. We see a proper lung volume. The lung looks good. And then this lung looks as well good. And then the heart is in the middle and looks okay. Here, the heart is taking up most of the lung diameter. In this section, we don't see proper heart here. Proper lung here. We see only small volume of this. Am I gonna say this is a cardiomegaly? No, because I know from a scientific point of view that probably when I do an AB view, anterior posterior, the heart will look the biggest. Okay, I want you just to learn this concept because I have seen people call a cardiomegaly an AB view, which is not correct. You need a posterior anterior to call it out, or you need a very large, big heart that is taking up all of the lungs to call it a really big heart. Cool? Cool. Move on. So the one reason or the one way for me to learn about chest X-ray is learning or seeing a CT scan. So let me show you a CT scan, which is a 3D dimension of an X-ray. Okay. To show you exactly how the organs are aligned. So this is an X-ray. I want you to imagine I'm doing an X-ray. So I'm seeing the blackish stuff are air content, and then the whitish stuff are heavier in their content. So let me show you how we see it. So I'm scrolling from,
the picture is not clear. It's not
clear? Okay. So let me just share again my screen. I think I just shared. Okay, let me share it again. Excellent. So this is a CT scan. This is a lung window in a CT scan. Don't worry about that. You're going to learn that later. It's not important. But I want to show you how a 3D image will look like, so you can imagine how organs are organized in the chest. So let's start from outside of your, I want you all guys to imagine going from outside of your lung. Okay, touch your sternum. So this is the bone. You see this? This is the bone. This is the sternum. And then when you open the lung, first thing we see is the heart. Okay, this is the heart. And then when you see around it, what is this black? All of this, these are the lung and the lung tissue. You see this whitish stuff around the lung? This is the lung parenchyma. It's the tissue that holds the lung together. Okay, and when you go back, I'm going towards the ribs, okay? Or towards the spine. So you see all of this is the heart. All of this is the heart. And then when you look back, you see the trachea here. You see the trachea? This is the airway. هذا مدخل هواء. Okay? هذا مدخل هواء يدخل هواء لللungs. It's not in the first thing ever, because when you look, you can see your chest, صح? You can see your sternum. That means the trachea or your neck is back. So the trachea is usually back. Okay? And I'm going back, and then we see the spine. You see the spine? You see how your spine looks like? This is how your spine looks like. And then you can see the ribs here. You see the ribs bilaterally? It's very clear, very beautiful. So this is a normal patient. Now I want to take a look downward. You see any blackness here? No, there's nothing here is black. Why? Because all of this is soft tissue. Okay, let me show it to you another modality. This is soft tissue window. That means I'm focusing on the soft tissue. This is all algorithm of CT. Don't worry about this. But I want you to focus that there is no blackness here. I'm not seeing black anywhere except here, which is inside the stomach. ممكن, this is what they call the stomach bubble. Okay, because the patient had ingested air while he's eating. Otherwise, I shouldn't be seeing any black in this region, below the diaphragm. Cool? Cool. Let's go back to the presentation. Going back. Okay. So I just showed you the CT scan. Let's move on. And then let me talk about how can you read an X-ray. What should you do? The most common way of doing this is doing an A, B, C, D, E. The same as doing a BLS, okay? This is the simplest maneuver. I have seen in multiple ways, but this is the simplest one. So we do the ABC. ABC, we start with the airway, breathing, circulation, stability, and exposure. Let's take them one by one. You start from the airway. Look at the trachea. it will be blackish because it contains air, okay? And then when you look at this, it goes to right and left main bronchus. In the middle, or the bifurcation, it's called the carina. It's the name of the division that's happening. It's called the carina. Going later, and how can you evaluate it? I want you to look at an X-ray, put your eyes on the airway, look at the blackish thing, follow it up to the right, follow it up to the left, and then this is how we do it. This is how your eyes should go. One, and then right, left. Cool? Cool. Simple as that. Move on. I want you to focus on something else. I want to see that when you look down, there is whitish stuff here. Okay, what are they? They are the pulmonary vasculature. They are the blood vessels. Okay, this is not a big thing. I'm not asking you to evaluate it. I'm just asking you, sometimes it can mimic or it can shadow your trachea, because we know that trachea is backward structure, صح? Anything is the front of it is the heart. So heart can obscure the trachea. So this is how the right pulmonary artery will shadow, and this is the left pulmonary artery. Just vessels going to the lungs. Don't worry about this. Look at the blackish stuff. B, going for B. So what is B? Is breathing. Look at the right lung. Look at the left lung. Look at the right. Look at the left lung. All I want to see just, is it really black or not? That's it. Okay. The best way to see this is going from apical. I want your eyes to go from the right to the left, right to the left, right to the left, right to the left. Don't go from upward to downward, because you're gonna miss anything. Because when you do this, I think the beauty of chest X-ray, it's the comparison. We have a right lung and we have a left lung. Compare it. And the way to compare it is dividing it to 4 sections or 3 sections, up to you, and then looking right and left, right and left. When you finish, look at the periphery, look at the outside. Just take a quick look. Is it really black or white? So this is black and this is white. It's cool. So we will later learn about pathologies, so we know exactly what to look for. When you continue, when you finish looking, look at the costophrenic angles. These are the things that's called costophrenic. The word costophrenic is costal, which means the ribs, phrenic, which is the diaphragm. So just an angle between the diaphragm and the ribs. It's not a big deal if you don't know the terminology. Just know there is a sharp angle downward, sharp angle downward. That's it. Then when you look at the diaphragm, it's continuous. It's okay. It's continuous to the left, continuous to the left, and then we have here empty. We don't have a diaphragm here because we don't have lung here. Okay, cool. This is the way I told you to look at the chest breathing aspect of the chest reading. You look from the right to the left, right to the left, right to the left, right to the left, and that's it. So you don't miss anything. Cool? Cool. And then moving on to the circulation. Circulation, I just want you to look at the heart. Is the heart going to the left side? We have the ventricle going to the left side. You have always heard that your heart is moving toward the left side, صح? This is a common terminology, common thing in our society. This is how the images are looking like. You see the tip of the heart will rotate towards the left side. It's not in the middle per se, just little tilting to the left side. Okay, cool. I wanted to show you this is the trachea, the airway, and then this is the hilum, and this is your heart. Cool. So we finished airway, breathing, circulation, moving on, disability, bones. I don't want you to focus more on the bones because catching one fracture is a miracle. Excellent, good for you guys. I would rather do a CT scan and check for the ribs because it's very difficult to catch. However, you can look at the bones. You can look at their integrity. Is there a fracture? Means a loosened line that's displacing them. If they are not displaced, it's very difficult for you to catch. And trust me, if there's anything wrong with them, you're going to see it because the ribs and the bones are usually okay, except in certain rare conditions. Okay, just I want you to know that they rotate. The way the ribs look like, they look straight because the posterior aspect is straight, and then they turned when they go to the midline. As I told you, we see the chest X-ray from posterior to anterior, but basically the straight thing is the posterior aspect of the chest. And then the rib, when it's rotated, it goes to the anterior aspect. We can't focus on this much. It's not important. I have never catched the pathology in the ribs in my entire life. Like, and then A, B, A, B, C, D, E. E is just looking at everything else, looking at the periphery of the chest X-ray. Look at the nipples. If there's a nipple shadow, just make sure this is what you are seeing is not a pathology, it's just a nipple. So usually you see it bilateral, symmetrical. That's a trick. When you see bilateral rounded structures, خلاص, this is probably a benign thing. Look at the outside of the image. You look at the outside, the soft tissue, and you look underneath. You look at the whitish stuff under the chest X-ray. That's it. And this is how you read a chest X-ray. Simple as that. حلوين. Let's start the full. يلا. Just let me summarize what I just said. So airway, trachea, bifurcation, then breathing, looking at the lungs, then circulation, looking at the middle structure. Now look at the bones outside, and then look beneath the diaphragm to look at the soft tissue structure. حلوين? Okay, let's start the pull. Yeah. I want you to go to my account, which is Arwa 067, and then I will start. You still see my screen, or it's disappeared? Hello?
We see the presentation.
Okay, cool. Yeah, I'm gonna make the first question active. Yeah, I want to see pulls. Okay, excellent. Okay, are you done, guys? Okay. Okay. في آراء قاعد تتغير. Okay, nice. I like that you are thinking and reflecting. Nice. Good. طيب, should we end it? Okay, excellent. So the right answer is the question. Oh, sorry. The question is, what is the view that's usually made with a portable X-ray unit on a very sick patient? Is the anterior posterior, which is going from anterior to posterior. Excellent. Now, let's move on to the next question. Okay. So this is a little bit difficult. Yeah. How does an X-ray passes in posterior anterior view? Very simple. Okay, let me end the poll. So how does it pass from posterior to anterior? From its name, it's going from posterior to anterior. There's no trick to this question. Excellent, guys. Deactivate. Yeah, move on to the third question. Okay, this is a little bit difficult, an anatomy question. I think that you all guys hate. Make it active. Okay. So I'm numbering the X-ray. I want you to look at it and give me your diagnosis. Oh, sorry, give me your anatomy. Okay, I like that. There's discrepancy in opinions. Excellent. You see, reality is everything is very subjective. The way we see stuff is different. So someone looked at this X-ray. Okay, let me see the poll. If anyone's done. Okay, let me see if everyone's done so that I can explain my opinion. Okay, I assume everyone's done now. Okay, so the answer in this question will depend on what you are looking exactly. Okay, someone who's seeing bilateral whitish stuff. Okay, if you are seeing the whitish, which is soft tissue bilaterally, let me share my screen. Okay, so anything. Okay, if you, let's say you are seeing this X-ray, you see the screen. Okay, you are seeing it. So if anyone is looking at this whitish stuff, those are the breasts. So female breasts, they look whitish. Excellent. But if I'm pointing at this line, then I'm probably pointing at diaphragm. So the answer is diaphragm. Okay. Someone answered the lungs. Lungs is very correct as well. If I'm saying this is a lung, this is correct. Diaphragm and the lung are very attached on the X-ray. They are overlapping. So lungs is very correct, by the way. Everything is correct. However, you need to see it in details. So I'm pointing to the diaphragm. So diaphragm is the correct answer. Cool. Cool. Let's move on to the second presentation. تمام. يلا. Now we will move on to the too much black lecture. Hello. Someone asked at the QA a question about pneumoperitoneum and stuff. We will explain it here. I hope that can answer his question. Yeah. I opened the wrong lecture. Okay, let me just. Too much black lecture. So we move on to the black lecture. Too much black. Okay. معانا كلكم. Yeah. Too much black. Okay. نرجع. We go back and review. So what are the black stuff on the X-ray? Is the lightest stuff, which is air, fat, and lungs, probably. And then what is the most brighter stuff? Is the heavier stuff. Metal, bone. Anything heavy, metal, bone, or kind of blood and muscle, etc. Okay, this is how we see an X-ray. So let's review a little bit of anatomy. The way the lung is surrounded, it is surrounded by two layers. Okay, or the way the lung moves inside the chest or the thoracic is they move smoothly due to the function of two layers. We have the parietal and the viscera. The viscera, usually the one that's attaching to the lung. The parietal is the one outside of the lung. So in reality, we have two layers surrounding the lungs, not only one. One attaching to the lung and the other one attaching to the wall or the thoracic wall. Okay, why is this concept important? For the idea of different things that could happen in the space between those layers. So if we have, for example, an air trapping inside the space, we are developing a pneumothorax. The word pneumo comes from air, so it's an air in the thorax. Thorax is the chest or the thoracic cavity, so we have a pneumothorax. This is the idea of pneumothorax. The air inside between the parietal and the visceral, between the visceral and the parietal pleura. And then, if we have, for example, blood trapped inside, patient had a stab wound or whatever, and he started to have bleeding inside this space, then we have a hemothorax. Hemo from hemoglobin, if you want to remember that. Hemoglobin, blood, thorax, chest. We could have two things at the time. No one made the rules, or no one is following any rules. We could have blood and air. If you think about it, air is lighter, صح? It will always go up. And blood is heavier. It will always go down. So now we have hemo, the going down, pneumothorax, blood, air, and the thorax. Cool, vocabulary, واضحة? I hope it's very clear. So, how does a pneumothorax look like in X-ray? If you think two layers of the chest. So this is an example of a pneumothorax. Let's follow our ABC reading. We see the airway in the middle, going right and left. It's okay, don't see anything wrong with it. When we look at our breathing, I look at the right side and then I look at the left side. It's darker here, too much dark, too much black. I see the right, I see the left, too much darker. I see here, I see here, so much darker. It's darker than usual. So this is our pneumothorax, okay? To confirm it, I want you to look. You see any lung tissue inside? This is the lung tissue. Do you see this whitish lines going all the way in this line? Do you see it the same here? No. What we see is this bulk of stuff. This is a collapsed lung. Because what happened here is that the air trapped and it caused this lung to shrink, to get smaller, because it's like an inflated balloon. I took out all of the air from it, and all of them ending with is a small inflated balloon. And this is what's happening. This is a pneumothorax. So this is a collapsed lung, and this is air filled in the space. Cool? What is the cause? Mostly it's trauma causes. However, it can be spontaneous. So patient in ER will present with a chest pain and he will have a pneumothorax. We don't know. But most of the causes are traumatic causes, which could be because of esophageal rupture, anything else, anything that can make an air trap in this space. Okay? The causes are a lot. You don't worry about the cause when you are reading a chest X-ray because usually you cannot really find the cause. You just suggest it and then you do a CT scan to look it up. Okay? So here's another example. Can anyone tell me where is the pneumothorax? Answer it in the QA, please. Is it which side? Okay. Chat. Okay, left. Excellent. So, excellent job. So when you look at this, all of this is a pneumothorax. All of this is black, extra black. When you look at the airway is central. When you look at the breathing, I'm looking here, 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 and then I see there is extra blackness here. I don't see it on the other side. And to confirm it, I don't see lung tissue here. Because this is just a free air that's trapped in the pleural space. And I'm seeing the lung being pushed by this air, okay? This is a pneumothorax. Move on. So this is another pneumothorax on the right side caused by a rib fracture. You see, I told you about rib fracture. You cannot really visualize it properly. If you are very smart, you could say this is a rib fracture, but usually you cannot really see it. What I want you to see, rib fracture is not important. The management of rib fracture is very limited. I want you to catch the pneumothorax, which is more important to catch. So I'm seeing, when I look at this X-ray, I look at the airway, right and left, and then I look at the breathing. I'm looking here, extra black, here, normal, black. They are not equal. This is extra black than this one. So this is extra lucent. Extra lucent means there is some sort of air in this space that is causing this to look extra black. Most likely it's a pneumothorax. The patient presented with symptoms of pneumothorax, shortness of breath, pain, etc. Then you could think of this as a pathology. Okay. So this is usually for the patient who are well healthy. They got to the X-ray machine and they got the X-ray. However, if the patient is really a trauma patient and he's really sick and he's in his back, we do, I told you before, we do an AB view, anterior to posterior, looking for air. Oh, sorry, looking for pathology. So we did an X-ray in this trauma patient, okay? I don't see extra blackness on the lung. However, there is a sign that is associated with pneumothorax if the patient is laying on his back. We could see something called the deep sulcus sign, which is basically an extra lucent or extra blackness that's going too deeper where it shouldn't go deep. So the diaphragm is here and that's going down lower than this. This is very subjective, but I want you to compare. This is the right side and this is the left side. Why is this too darker than this? Shouldn't be. So this is a deep sulcus sign, which is associated with pneumothorax. If you think logically about this, the air will go upwards, صح? but the patient is laying on his back. So it goes to his upward and will go down, or on the highest part of his body, which is usually his stomach. So when you lie down, the highest part of you is usually the stomach or the top of your chest cave, chest thorax. So it will go down. So this is a deep sulcus sign, which is a sign only seen if the patient on his back. If he is on his erect position, if he is standing up, if he is already unhealthy, and this is a posterior anterior, I wouldn't see it. I only see it when he lays on his back. Okay. So this is another example. Can you tell me where is the pneumothorax in this patient? Good question. Right. Excellent guys. كلكم رائعين. طيب. كان في سؤال يقول why is the trachea is not pushed? Okay. Now we're going to talk about it later in the presentation. So this is spontaneous pneumothorax. This patient had a lung disease that made him have a spontaneous pneumothorax. So the concept, I want you to understand that the concept of pneumothorax, you always assume it has to be trauma. It has to be he went to a car crash and that's why he has a pneumonia. No, it's not. You could have a spontaneous pneumothorax. You could have iatrogenic from something we already administered. This patient, if you look at his CT, he's some sort have a cystic lung disease. So let's say, I mean, no, CT is very difficult to read, but let's imagine. You see this is cystat, cystic structures inside his lung. He has a cystic lung disease, and that's why he had spontaneous rupture of one of them, and then he had a spontaneous pneumothorax. You see all of this is very dark, very black. I don't see any tissue here. So this is the pneumothorax. If you see here the pneumothorax, and then you see this is cystic lung disease. Okay, cystic lung diseases are very common and very, not that common, but they are in our society. And patients who are, let's say, tall, who have Marfan or have a, whatever, they could present first thing with a pneumothorax, spontaneous pneumothorax. They present to the ER with sudden chest pain. That's not associated with trauma, and you figure out they have pneumothorax. You wonder why, and you do a CT. You discover that they have a cystic lung disease or whatever. Now, there was a question called why there is not, and why is the trachea not pushed? So there is a lot of focus on the tension pneumothorax. ما في TV show you have ever watched إلا ما جابوا طاري tension pneumothorax، استرواح الهوائي. وكل مرة يجي البطل الرئيسي في المسلسل وتبر يدخل لك تيوب في الشست، يفتح لك الايرواي ويحسن التروية حقت اللنج. Okay. We have all seen this scene happening at some point in our life, okay? But tension pneumothorax is not that common, by the way. It's common, but it's not that common it doesn't happen every pneumothorax. That's it, out that there. So what is a tension pneumothorax? Tension pneumothorax, when the air is too much, it's too dark. You see, this is different than our previous study. It's too dark, okay? It's causing the lung to collapse, all of it, and then it's pushing on the trachea. Why is it pushing it? Because the air is keep accumulating. So this happens only, let's say, in a patient who has a chest injury, and there is a valve happening. So he still have air still accumulating. And this is how we had his vital signs being compromised, because now he cannot take a breath at all. So we see contralateral mediastinum shift. So we see all of his mediastinum or the heart structure and everything is to the other side. I try to locate the trachea, cannot see it. I see it rotating to the other side. This is the lung tissue, and I'm seeing the pneumothorax too large. And it's causing the diaphragm to be flattened. Let me show an example. This is tension pneumothorax. This is where the air is too much, that's pushing everything to the other side. You see the trachea is going to the other side, all of it. And this is the air. How to confirm? Again, go to the clinical history. If the patient having a sudden chest pain and he's having decreased his vital sign, he's having decreased oxygenation, he's in severe pain, then this is probably a tension and he needs to have a chest tube immediately. However, if you are dealing with a small pneumothorax, the treatment for that is usually management conservative. Because the normal pathophysiology of pneumothorax is that if there is a free air in the lung or in the pleura, the body has the ability to absorb it back. But if there is an injury that's happening and it's keeps the air accumulating, and there is no relief of it, then we start having a tension. then we have too much tension in the lung and all of the structure are pushed to the other side. And this type of patient will need for sure a hero in the movie series, okay? To need someone to put a chest tube in this, okay? Cool. طيب. Okay, is that clear? يلا ننتقل اللي بعده. Okay, can anyone tell me what's wrong with this image? يلا كنتوا مركزين معاي بتعرفون. Can it be from a hypercapnia? The causes, يعني, I don't want to go through the causes. Pneumothorax, okay, excellent. Yeah, excellent job. It's a pneumothorax. You see the leveling? Okay, excellent job. Pneumothorax, excellent. I don't care how you organize it. Is it pneumo first or hemo first? As long as you understand what is this. This is probably an air accumulating. Sorry. Someone said the right. This is the right, by the way. This is the left. So if I see the airway is pushed to the other side a little bit, but that's okay. And then I'm seeing the airway. I look at the right, I look at the left, right, left. I'm seeing here is extra dark, extra dark. Okay, and I'm seeing here leveling. I'm seeing air, and then here is extra whiteness. And I see the lung being pushed. So in this patient, he had a pneumothorax, which basically an air and hemorrhage. In this history of this patient has a stab wound, someone stabbing him, and he had injured vessel, plus he injured his lung at the same time. So he had bleeding and air outside their normal location. So he has a bleeding inside in his pleural space as well as air. And that's why you have this appearance. Okay, excellent job, everyone. And then, see, I told you there is a cause that is usually traumatic, but I'm telling you this is an example of a patient who is not a traumatic. This is an example of a patient who had also a pneumothorax. Let us look at the X-ray. So the airway is central, it's in the proper location, and I see the right and left, right and left. Right. I'm seeing here is extra black. Okay, shouldn't be there. This is not the same. So extra black on the left side, sorry, the right side. And then I'm seeing leveling. So I see air going up, fluid going down. So what is this air and fluid? It's pneumothorax. This patient had a spontaneous pneumothorax. Let me show you the CT scan. I like a CT scan because it gives you three-dimensional view so you can understand better. So let me open the CT scan for you guys. Give me a minute. There's so much questions. I'm sorry if I'm not answering any of them. But hopefully I will be able to I'll be able to do it in the end of this lecture. Yeah. So let me share the screen. Okay. Do you see my screen now?
Yes, doctor.
Right. You see the Radiopedia site, which is our guide. Right. This patient had a pneumothorax. Okay. I want to show you how it looked like. So let's go back to the way we did the CT scan previously. So this is the heart and this is bilateral lung, okay? You see it's dark bilaterally. So where is the fluid? Where is the air? Where is the fluid in this patient? It's not. I'm going back to his spine. And then when you go to the spine at the level, it's not equal. It's too much fluid here and too much darker here. Okay, it means here's the fluid. Why is the fluid in the whole lung layered like this? Because think about this. This patient is laying on his back, so probably the fluid in his back, okay, next to his spine, not anterior. And that's how it will look like. This patient, they found out there is a bleeding from one of the vessels from up. Such extra details. This is a job for a radiologist to figure it out. So again, this patient, I'm showing you the axial CT scan. Okay. I want you to see the leveling in a CT scan, how it looks like. You see the air here. It's not a lung tissue. This is pure air. It's too dark. You see it, how dark it is? It's similar to the outside air. So when you see the scan, there's darkness or there's blackness outside of the patient. This is room air. And then this is also the room air. Similar. And then we see the extra whitish stuff. This is probably a bleeding. حلوين? Move on. طيب نرجع للlecture. So this is a pneumothorax. Okay, this is spontaneous, but it can be usually from traumatic or it can be spontaneous. Move on to the last two things. We have the mediastinum. So I told you the heart is in between the two lungs, okay? So what happens when we want to see air within the mediastinum? So think about this. The air or the free air or the extra blackness stuff, when it's in the mediastinum, it will not push the lung because it's not related to the lungs. It will go back and forth in this space, in this mediastinal space, okay? Let's see this heart. So you see the heart here, and then you see extra lucency here, extra blackness. Is that clear for you guys? So here black, extra black, extra black, extra black, and then I see here extra black, extra black. So I'm suspecting this is probably a pneumothorax. Probably pneumomediastinum. Pneumomediastinum. It's an air around the mediastinal structure. This is an example of a pneumomediastinum. I'm showing you the CT and the X-ray. So if you're in the CT and the X-ray, you see extra lines, blackness, okay? Black, black, black line. They all are free air, okay? Going through the mediastinum. It's not pushing the lung because it's not related to the lung. It's not entrapped in the pleural space. It's trapped in the mediastinal space. When I see it on the CT scan, you see the darkness. It's as dark as the room air. You see, this is outside of the image. This is dark room air. So it's dark as the room air, it's dark as the air in the trachea. So all of this is free air surrounding the mediastinum. So this is a pneumomediastinum. This is another example of pneumomediastinum. This is a trauma patient. He had a very severe injury to his trachea and esophagus. Something was injured, probably his trachea. Air escaped from his trachea and went into his mediastinum. And that's why he has a pneumomediastinum. So the air is surrounding his pneumomediastinal structure. Let me show you the CT scan so you can imagine how the air is, the air is surrounding the structure. Okay, let's go. You see, I'm not interested in teaching you the causes of things. I just want you to catch it, okay? To recognize that this is not normal. Let's figure out the cause later. We just need to address it. Is it something urgent or not urgent? Okay, this is my target. Okay. You see my screen now on the Radiopedia page?
Yeah. Yes, doctor.
So again, this is our X-ray, okay? I'm seeing air, extra air, lucent, black, black, or extra black. I don't care what you call it. Just recognize there is an extra darkness around the mediastinum where it shouldn't be dark, okay? Then if you see the CT scan, I wanted to show you exactly what I'm talking about. So let's go back from this sternum. We are going back from the study. And we see the extra blackness, true blackness here. This is all air around the heart. You see it? It's around the heart. It's called pneumomediastinum. Okay? Pneumomediastinum. And when you go back, it's when the pneumomediastinum happens, it doesn't go to the lungs, by the way. It goes upward. It goes to the neck. It descends through the neck because we know for a fact that our mediastinum is connected to our neck, by the way. There is a free space that connects the two. If you think about it logically, you have all your heart and the esophagus and the trachea, and all of them, the esophagus and the trachea, all of them go to your neck, صح? So sure you have a connection to your neck. So you have a connection to the neck, and you see air around the mediastinum. Okay, cool. This is what I wanted to show you. This extra blackness, because all of this is just air surrounding the mediastinum and going back to the neck. Right. Let's go back to the PowerPoint. Right. حلوين. So pneumomediastinum probably is traumatic. There's another traumatic injury to the esophagus that can cause a pneumomediastinum. If the esophagus, which is a posterior structure, يجي جنب التراكية. Okay, يمشي هو جنب التراكية. This is a common thing we see with alcoholics, with people who vomit a lot, people who had spontaneous pneumomediastinum where we don't know what's the cause, probably from this. So what happens is that they cause a small injury to their esophagus, where when they swallow air, it descends and it spreads.
When he has so much air in his stomach, it descends and spread in his mediastinum space, which is this space. It doesn't go to the lungs. It's not a pneumothorax, it's a pneumomediastinum. This is a patient with Borjev syndrome. I'm not asking you to diagnose it. I'm just asking you to recognize what is the free air and then realize where is it and is it a pneumothorax or pneumomediastinum. So if you look at this, he has extra blackness here, which shouldn't be behind the heart. I shouldn't be able to see blackness behind the heart. So what's the cause? And we look at the rest of the image. There's extra blackness around the mediastinum, extra blackness around the in the neck. It's called an emphysema, but it's a black thing. So this patient had a Borjev syndrome. Right. This is an X-ray. I want you guys to tell me your opinion about this. What you don't like about this X-ray? Can easily be missed. Of course, it's easy. I have missed many pneumothorax and pneumomediastinum, pneumoperitoneum all the time. It's okay to miss as long as you learn from your missing. Can it push the pericardium? Guys, I want you, by the way, to look at this X-ray while أمزح. خلينا نجاوب الأسئلة بعدين. نحس قاعد أغير. Pneumothorax. Okay, this is an answer. Excellent. أعطونا another answer. أعطونا another try. Yeah. Pneumomediastinum the right side. حلو. I like the idea. Nice. Excellent. طيب أعطونا another answer. واضح إن ما عجبتني answers. أعطونا another answer يا شباب. يلا. Pneumomediastinum the right side. Good thinking. Okay, I like that, but no. Right side schizophrenic angle deep. Oha, hello, ya Abdurrahman. You are too close. Emphysema or liver. Okay, I like this. I like it. Okay. So, sure, cool. Air under diaphragm. Oh, this is the excellent answer. Okay, good job, mentor. So, you look at the lungs. Right and left, right and left, right and left, right and left. They're all okay. Okay. And then you see this line. These are the edge of the diaphragm. And I'm seeing extra blackness under the diaphragm. Okay. واحد كاتب right schizophrenic angle is too high. Excellent. This is a rotated image, so I'm sorry about this quality, but let me show it another example. But I wanted to show something. So this is airway, okay. Lungs are okay, and then I'm seeing air, or I'm seeing extra blackness under diaphragm. And I see it on the left side as well on the right side. You see the left side, I'm sure his should be the stomach, but there's extra air, and here's extra air. And this is what you called pneumo, which is air in the peritoneum. Okay, let me show you another example so I can teach you this. Okay, this is a better example of air under diaphragm. So this is CT scan of an abdomen. This is not a lung, this is an abdomen, okay? I'm seeing dark, black thing around the liver. It's under the diaphragm and it's above the liver. So this is not coming from the lung, it's coming from downward. And this is what we call the pneumoperitoneum. It's air in the peritoneum space, okay? Look at the X-ray, try to translate it. So I'm seeing the lung, it's finished here, and I'm seeing extra. So there is a white line, and then under the white line, there is another black line. And this is what air does, by the way, to tissues. If there is two airy structure together, so this is an air and this is an air, it will show anything in between as brighter, as whiter, as more prominent. So this is an airy structure to the lung, airy structure 3 air, to look the whitish stuff as very prominent. So you start seeing it very clear. And then if you follow it, there's air under the heart. I shouldn't be seeing air under the heart. There's no tissue. There is no lung behind the heart, by the way. I shouldn't be seeing air at all. So if I'm seeing a continuous diaphragm or a continuous line of blackness between the right side and the left side, I'm dealing with free air in the abdomen, not in the chest. Why I'm teaching you this? Because a lot of cases we do a regular X-ray to our patient and then we discover incidentally that he has a pneumoperitoneum. Something ruptured, an airy structure ruptured in his abdomen that caused him to have a pneumoperitoneum. Okay, so this is an example of pneumoperitoneum. Another example of continuous diaphragm sign is basically an air that is continuous under the heart. I shouldn't be seeing air under the heart at all. but I'm seeing it continuous. Why is that? Because it's not even inside the lung. It's not even inside the diaphragm or up above the diaphragm. It's all below. It's all in the stomach. The causes are different. So it could be spontaneous. It could be anything. In the previous example, this patient had a peptic ulcer disease where he had ruptured of his ulcer. So the air escaped of his bowel and it went into inside the peritoneum. Okay. I'm not gonna go into details. We're gonna do that later. Okay, so in summary, we learned about the concept of too much plaque, which is air. We learned about pneumothorax, pneumomediastinum, and pneumoperitoneum. Okay, I hope all of you understood now what are these concepts. Let's go for the quiz. Okay, let's go for the quiz now. Let's start. So what is this? I'm making it active, okay? I hope you all are able to answer. What's the retributive answer? Okay, this is extra information. You'll learn it later on. It's so patient who has so why is there very strong? In which case are you able to see the quiz? Okay, hello. Let me see. What is your answer? Why is there too big stomach bubble? So air bubbles or stomach bubble, it happens when the patient, so I assumed probably he is trying to gasp for air. So air is going in, but it's not going to his lungs. It's probably going to his stomach. That's my explanation. But usually we see air in the stomach all the time. People who chew with their mouth open, they inhale a lot of air inside. So you see it a lot with the stomach. And it's normal to have air in the stomach. It's not a big thing. So what's the diagnosis? I liked the people who said right pneumothorax, but I even love the people who said right tension pneumothorax. Excellent job. You see a huge black thing pushing everything to the other side, even the trachea. Okay, left pneumothorax. Probably you are mistaking it for the right and left because you're not quite sure. By the way, in X-ray, we switch order. So the right structure will be on the side of the liver and the left structure on the stomach side. But I understand the confusion because it took me a while to get used to it. Excellent job. Yeah. Excellent. Move on. I don't care if you catch attention or is it a regular pneumothorax, as long as you catch there is free air that shouldn't be there. That's my target of the day. طيب. اللي بعده. يلا هنشوف الأدب. Okay. What is this sign? I spoke about this before. يلا, excellent answers. يلا. Excellent. Air under the diaphragm حلوين بس مو it's not the right answer. It's not the right answer. طيب. يلا. يلا. So the right answer here is deep subintestine. We talked about this before. So the deep sulcus sign is when we have an air that's extending too deep beyond the diaphragm of the chest, because probably this patient he was laying on his back and he's an AP view, not a posterior anterior. So the air didn't go up, it go down, which is a sign of pneumothorax. Okay, last question, we will take a break. يلا. هذه سطل، هذه اللي ايزي نست، اللي مركز بشوفها. يلا. يلا. هذه اوكي. طيب حلو, excellent. So what is the abnormality here in this question? I hope you guys are done. I'm closing the poll early for ناخذ break. So the abnormality here is probably air under diaphragm. So the diaphragm is very prominent, more than usual, and there's air underneath. So this is probably a pneumoperitoneum, not a pneumomediastinum. Pneumomediastinum is a good option. It's a good thinking. It's not bad. However, there is an air under diaphragm, so probably he has a subtle free air. So we will take a break for extra 5 minutes. Okay, go do something, and I will review the question and write them down so I can answer them at the end of this lecture. Yeah. I will mute. I will أنا قلت بسوي حاجة. First question, what was the correct answer? It's tension pneumothorax. It was right side tension pneumothorax. It's tension because it caused the mediastinum to shift to the other side. So break time. Okay, I'll review the questions and then answer them when I'm done. Okay, take a break, guys. ونرجع ل 11 و10 دقائق. يلا. Let me answer a couple of questions قبل ما نبدأ بال okay. So tubes and lines. We are gonna start with the tubes and line lecture. كان في كم من سؤال من previous lecture. Let me answer them very quickly and then we move on to our second lecture. New share. Screen share. Okay. طيب خلينا نبدأ بأول سؤال. كان السؤال الأول هل الهارد ورك اوت تجيب pneumothorax؟ Possibly, why not? Injury from هنا, injury from هنا can cause this. However, it's less likely. You need a very aggressive workout injury so that you can develop pneumothorax. السؤال الثاني, when can we say pleural fusion? I would keep that question to the last study لأنها study of white stuff. So, last lecture and then her lecture حقت white stuff. Can a pneumothorax push the pericardium? Can a pneumomediastinum push the pericardium? The answer is possibly yes. The air, when it's trapped inside a closed structure, say lungs, anywhere in the body, doesn't matter. It will always cause damage if it keeps pushing. Okay? So the answer is what is the modality usually, or what is the cause of the air in that structure? And then what is the cause? Usually we treat patients who are symptomatic. So if he's complaining, or the patient complaining of something, we treat them. So an air in the mediastinum can be a possible pressure on the mediastinal structure and can push the pericardium. It's a possibility. However, it's less likely لأنه لو فكرنا فيها, it can have a more diffuse space to go through if it's going to the neck. So again, you need to look at the patient's symptoms. If he's symptomatic, if he's complaining, if he cannot take a breath, if he's very tachycardic, etc., then probably there is some element of pushing and you need a further cardiology consultation where the cardiologist has to be involved. طيب. What is a ruptured duodenal ulcer? I think I answered that. Is just هي القرحة سمعت فيها من قبل. أحد عنده قرحة معوية. Basically, it's from an excess acid in the body. Or his body is causing or creating excess acidic structure. So his layers of his duodenum or the stomach, whatever, start to get very thinned out, and then suddenly he can rupture or he can have a small hole in that structure, which can release air inside the peritoneum. So this is a duodenal ulcer rupturing. Someone asked, can we see the ribs from the back? Yes, we see the ribs from the back and the front. However, all you have to see is that these are ribs. And if you want to spend time looking at them and following each one of them, that's on you. But I'm telling you, probably it's very difficult to pick up a lot of stuff from the ribs. Can the question يقول لك what's the lung border? A lung border, just the apex and the diaphragm, and they go from the medial to the lateral. If you see the presentation, I draw or there is a drawing of a yellow line along the borders. Just as a rough idea. If you want detailed anatomy, I always say I'm willing to give a detailed anatomy, but I don't. I'm not willing. طيب. You need to study anatomy for that because the details are really big. But lung border usually is just the apex of stuff. أحد سأل قال can the pneumothorax push the diaphragm or cause a depression in the diaphragm? Yes, it can. If it's continuous and it's continuous to push it. طيب في أحد سأل lastly lobar pneumonia, bronchial interstitial كيف نفرق بينهم? That will be in the last lecture because I'm going to explain the whitest stuff في lungs. طيب نبدأ. يلا نبدأ second or the third lecture. So I have seen a lot of people make mistakes regarding these. These are the killer mistakes in the hospital. This is my opinion. Tubes and lines. Okay, let's start. Let's start with the first tube. Someone asked a question. Right. Okay. طيب. يلا نبدأ. Tubes and lines are a lot of people have problem with tubes and lines. So let me, or hopefully, simplify it for you guys. So نبدأ بأول tube, which is the most common tube. You see it in ER, in any patient in the ICU, etc. We have the endotracheal tube. or you could call it a tracheal tube. I don't care, call it whatever. It's a tube through the trachea, through the airway. What is the proper position? You should put it 5 centimeters from the carina. You remember what's the carina? It's the bifurcation of the right and left. Okay, this is how the patient presents. It's a tube through the airway, which is his mouth, through his trachea into the carina, or into the level of the carina, 5 centimeters. Just an information about trachea tube. When the patient has a trachea tube, it can go up and forward, upward or downward, depends on how he moves his neck. If he moves his neck down, which is called the flexion, then the tube will go deep, because you can. It's like you are pushing it downward, so it goes deep. But when he extend his neck, which when he goes with his neck backward, okay, now it's called now the tube will be raised to the upward. I want you to understand this information because it helps you later on understanding the positioning or the how the trachea tube is assessed. So not all of the tubes are low. Sometimes they are just based on the appearance or the patient where he is moving his neck. Okay, right. So this is not a great example. I'm sorry about this. Let's move on to the next example. Okay, this is a tube. If you look at this whitish stuff, this is endotracheal tube through the air. And then if you see it, it's between the carina and the bifurcation. This is a proper location. This is what it should be. When we evaluate tubes online, we look at their tips. The tip nafsa. Look at the tip. It's above the bifurcation. Excellent. Excellent location. Move on. Someone asked a question. Sorry, oropharyngeal anastomy. Yes, correct. This is an oropharyngeal. I apologize about this. I did the lecture very quickly. Excellent job. Right. Oops. Right. What happens if the tube is too deep? So this is an example of the tube being too deep. Whomever did the tubing, they insert the tube, and then when you look at it, it went to the right side and missed the other trachea. So it only went to one of the bronchi on the right side. It missed the other side. So what happens is that we are introducing air and inflating the right lung and making it have extra air inside. So it looks black, it looks okay, it's fine. However, the other lung became too white because there's no air inside. So this is a misplaced tube. We need to call the person who inserted, etc., and then they need to adjust it. This is an example how they are inserted. So endotracheal tube, we insert it, and then it is on the right. It went too deep. You see the bifurcation here? It went too deep to one of the sides and missed the other entrance. It should be above, صح? It went to the right and missed the other side, and that's why we have all of this blackness, because it didn't get any air inside. So this is a misplaced tube. This is another thing that's not related. Right. This is CT scan. I wanted to show you how a CT scan looks like. So we inserted the tube. You see the tip of the tube is in the right main bronchus. It's below the carina. It's below the bifurcation. It's not a correct positioning. What happens is that the patient had collapsed left side because they didn't get any air to expand it. I didn't inflate it. So it's a collapsed balloon. Okay. And when you see the collapsing, all of the structure moves to the other side because there's no volume on the left side. This is an example of a collapsed structures because of the tube is not in proper location. This is CT scan lung view, just to show you that this is the tube too deep in the right side, missing the left side airway. This patient or the previous patient had a corrected, so they pulled it upward a little bit at the bifurcation, and the patient is fine now. I'll show you the CT, but we are late and we are a little bit running late. So this is another complication of endotracheal tube. So let's look at the airway. So we are looking at the airway. This is a patient who was introduced. This patient had an X-ray before and after they inserted endotracheal tube, and before and after multiple follow-ups. So this is his normal X-ray before, and he was fine. He didn't have any problem. He didn't have any pneumothorax or air or anything else. We introduced an endotracheal tube, and he was followed up in the ICU for a while now. he developed shortness of breath, so they increase his oxygen and they increase his oxygen demand. Okay, what happened is that because of the high pressure from the airway or giving the airway to the lungs, the patient developed this appearance. If you look carefully, we have, as we studied earlier, we have lucency around the mediastinum. So there we have a pneumomediastinum. We have also pneumothorax because there is blackness around the lung. We have also emphysema around the neck. All of these happen because we introduce so many pressured air from outside. This is what's called barotrauma. Bar from the pressure, barotrauma. It's a trauma happening from the pressure we inserted or we gave to the patient. It's very rare to happen. However, it happens. I want you to be aware of this when the patient suddenly develops auditory rate while he's on high oxygen demand. Then you should consider maybe we are injuring him by giving him too much air. And when you look at the X-ray, be careful of the excess blackness in the image, looking for any signs of heart trauma. Okay, this is just an introduction of an idea. Another thing, we could have a tracheostomy tube. This is not this is a prominent tube that is introduced to the patient usually. So we insert the tube, or we have the tube in the mid trachea. It's not from their mouth or in the tracheal. It's from their trachea. Okay. So this is usually a fixed tube. We don't see much complication with it because it's done for permanent causes. However, we could see pneumothorax, with mediastinum, mediastinal hemorrhage, etc. But it's very rare. This is the normal. So this is a tracheostomy tube. So it's not endotrachea. It's not coming from the trachea. It's from mid. So we have the tube here. As I told you before, anything that's metal will look brighter. And this is probably a metal plastic. I assume it's metal. So it will look brighter on the X-ray. So this is the normal positioning, and you see it inserted. It's very small, but just to introduce air. And then this is a complication, which is very rare. However, I wanted to show you that it might sometimes be misplaced. So now the appearance is weird. It's crossing the trachea, which is the airway here. It looks weird, so probably not a proper location. Call someone, consult someone else about this X-ray, and you probably agree that this is abnormal. You do a CT scan. This is the airway. This is the black thing. This is our airway, and you see the tube is outside of the airway. So it's an outside tube. It's very rare complication, but it happens. Now let's move on to another tubing, which is nasogastric tube. It's the most tube that is inserted in patients. We give a nasogastric tube. We introduce the tube, and then it's go to the esophagus, straight up, and then to the stomach. I want you to understand one thing is that the tube should be under the diaphragm. Under the diaphragm. That's the most important trick. Okay. Complication, it can coil upward, it can coil here, it can go to any of the wrong places, can perforate, it can go anywhere. Just I wanted to know the normal location of it, and then we would deal with the complication later. This is the normal. If you look at the tube, this is the tube. It's a white line going through the esophagus, so it's behind the trachea, and it should go straight, reach the diaphragm, and go under. Cool. Straight, reach diaphragm, and go under. Here, straight, and then it's go to one side. That's abnormal. The esophagus is a straight structure. It shouldn't go to anywhere. So now it's going to the right, and it's going to the other side. What's happening in this X-ray is that instead of giving it or inserting it into the esophagus, we insert it by accident into the trachea, and it's going to one of the tracheal structure, and we insert it too deep, so probably we injured some of the structure here. So this is a mal-placed. I don't care if it doesn't matter if you figure out the proper location exactly, as long as you understand this is not a proper location. The nasogastric should be coming from the nasal, going to the esophagus straight up and under the diaphragm. This is turning around. Why should it turn around? The esophagus is a linear structure. Also, in this patient, he had extra blackness on his right side, so this is probably pneumothorax, and the lung is being pushed. Okay. This is a nasogastric tube. It's a common complication when someone is inserting the nasogastric tube in a rush. They could coil it up in the neck. All they have to do is just pull it out and reinsert it again. This is just an appearance of a coiled up tube. Okay. You could see it in a partial X-ray. You could see it quite up here. You see? They try to insert a nasogastric tube, but it's quite upward. Okay. Cool. This is another example. Can anyone tell me what's happening in the chat? Okay. Right lung, excellent. Right trachea, excellent. To the right, excellent. It's all of you are right. It's going to the right side, which shouldn't go there. If we are anatomically corrected, it's going to the trachea and going to the right bronchus, puncturing it probably, and then inserting into the lung. So we have all of this is wrong location. Where it should be under diaphragm, straight down, that's it. Right. This is an interesting case of a patient who had an abnormal gastric tube. It's too much information, but it's he had a nasogastric tube that's coiled up in his esophagus and then coiled up back and inserted again in the stomach. Very interesting, but I don't think you're gonna encounter this later on in your career. Let's move on. Now we talk about the lines. The tube is analyzed regarding the vascular structures. So we usually give treatment through lines. We insert them into the venous or the arterial system. Okay, mostly the venous system. So we can give antibiotics, treatment, fluids, etc. We have different lines. All of them are called the venous catheters or venous lines. I'm going to introduce you to a couple of them, but I want to go after this lecture with one information, that their proper location should be on the superior cavo-atrial junction. Superior cavo-atrial junction. What does that mean? It's the area where the superior vena cava inserts in the right atrium. You don't have to know much of the anatomy. I want you to look at the trachea here. You see the right main bronchus, which is the blackness here. It should be in this proper location. That's it. It should be below to it a little bit, but this is a proper location. That's it. Okay. This is just an extra visualization so we can imagine what's happening. But if you don't know what's the superior vena cava and right atrium, if you always get lost, etc., just understand that it should be below the right main bronchus. Okay, it should be below this one. It should be in this location. That's it. The tip should be there. Anything else, it's abnormal. Okay. In this patient, this is a central line coming from the jugular usually. They insert this in the jugular. I don't care, just coming from the neck, probably it's central. So this is another central venous catheter. This is another location. It's going from the venous, whatever, and then going downward. I'm seeing this is the trachea, this is the right main bronchus, and then it's in this location. The tip is there, so I'm happy about this. This is just a reformatted image to show you the proper location. So it's called the cavo-atrial junction, which is the superior vena cava to the atrium. Just sounds sophisticated, but if you forget this information, I want you to understand it's just below the right main bronchus. That's it. Right. So in this patient, okay, the line went this way, and the tip is going to other side. It's not going downward. It's high and going to the other side. So this is malpositioned. Plus the patient had an extra blackness here, which is pneumothorax. Here, you see the line going downward. This is the right main bronchus, which I told you it should be around this location, but it's going too deep. It's too low. I don't want to give you measurement, but it's going and still it's reaching the diaphragm. So this is very deep line. Deeper lines are very dangerous, by the way, because they are inserting inside the heart, صح? So they can cause arrhythmia. So this is a malpositioned line. It should be corrected. Like, this is another central venous catheter. So another I inserted here, or people who inserted here, but instead of going downward, it went down and left and the right side. This is another malposition. Where it went through, I don't know. It punctured something for sure. It punctured the subclavian vein probably and went to the other side. This information is added information. I just wanted to know this is abnormal. This is not okay. We need to call someone about it. So another line is called the peripherally inserted central catheter, which is basically, we went, instead of central from the neck, we went from the arm, which is a peripheral structure. So if you see the direction, it's went from the arm upward and then downward. Again, it shows the same rule. It should be below the right main bronchus a little bit in the cavo-atrial junction. That's in our location. That's it. Okay. Anything deep, anything up, anything other directions, abnormal location. Need to be corrected. This is another normal, but this time it's coming from the left side. So we can insert it from the left arm or the right arm. It's okay. They could put it anywhere. Again, it's at the level, at this proper location. Okay. Here is an example of a patient with abnormal central line. If you look at the abnormal peripheral line, we follow the line here. And when it's come to this location, it's tipping upward. The tip shouldn't go up, it should go down because it's going to push drugs and medication downward. The tip shouldn't be in this location. So in this location, going upward. This is malpositioned, peripherally inserted venous catheter. Okay. Okay. This is another example. If you are very careful about looking, this is the line. And when you look at it, it goes to the axilla and then go back. It's abnormally inserted. It should not go back. It should go to the right side. Okay. This is another one. We inserted the line from here. Our intention should go to this location, but instead it went up. Whether we insert upward or downward doesn't matter. Always you can go back to the history and ask the patient or ask the physician. They always have documents what line they inserted. And then you follow the direction. And this time, this is abnormally directed. It didn't even went to its right location. So this is abnormal. This is a line that's too deep. دخلنا عند ال right main bronchus. It went too deep to the diaphragm. Probably this patient had arrhythmia or something. That's why they did the X-ray and they found out the tube is too deep. Sometimes patient can insert it themselves. يعني يدخلون بزيادة يعني يعمقون المكان. Okay. So this is briefly inserted line. There is also other lines we utilize. It's called the tunneled central vascular catheters. Just said excess fancy words. Basically, patients who are chronic patient, they usually insert, or patient who needs medication for a long period of time, they could insert catheter lines by IR. They do a portovenous catheter or portacath. Basically, they can insert the medication through the porta to the patient line. It doesn't matter what it is, as long as it follows the same regulation. It should be at the cavo-atrial junction. That's it. It should be below. So this is the portacath and this is the line, and then it should be below. Okay, this is the proper location. This is just a portacath. Because it's chronic, it can have another complication. It can be broken. In this patient, he had a broken portacath. It's broken down and the line went down in the heart. It's very unlikely because now they have a regular follow-ups, but you could have a broken catheter, which is a common thing. Okay, summary. I introduce you to a couple of lines. Endotracheal tube, which should be 5 centimeters from the carina. NG tube under diaphragm. That's the most important thing. And most of the central vascular lines, whatever it is we inserted in the patient, it should always be on the aortocaval junction or just below the right main bronchus. Okay, so let's move on to the pull. مركزين معي ولا؟ يلا. تدخلون على الصفحة. يلا activate. Okay. Okay, excellent job, everyone. It's a central line. So it's going from upward to downward in the right side. It's the proper location, which is in the right side. So this is central line in the right proper location. Excellent job. Yalla. السؤال اللي بعده. طيب so يلا خلينا أوريكم إياها. activate. This is so if you are forgetting, PIC line is peripherally inserted line and NG is nasogastric tube. Nasogastric, okay? وفي PIC line. Just remember the way they are named, it follows their direction. So when I say nasogastric, to go from the nasal to the esophagus to the gastric, because it's intended to go downward. Okay, and it should, you start seeing it from the neck. If I'm saying peripheral line, it should come from your peripheral sides, which is outside, and then come inside. يعني من arms ويجون على الرئة. Okay, yeah, excellent. Abnormal. This is an NG tube in the right main bronchus. دخل ولف على الجهة الثانية. Excellent. شطورين. طيب آخر سؤال in this section and move on to the last lecture. Yeah. آخر سؤال. Activate. والله حلوين شطورين شطورين. Excellent job everyone. يلا استمروا. So it's very careful to look at the extra structure or extra stuff. يلا. about more responses عشان أقفل الكول. عادي جاوبوا غلط. It's okay. I'm sorry. Can anyone assist him about the way he can get the questions? أتوقع في جزئية فوتوا المقطع. Yes, okay. Okay. So, بس عشان أكتب حقتكم. So, excellent job, everyone. So, in the patient, he had his NG tube because it's going from the neck downward, okay? And then instead of going straight down because it should follow the esophagus, it went to the left side. And extra information about this case is that he had, please share screen عشان بس الأشخاص اللي ما شاء الله. طيب. In this question, so it went straightward and rotated, which shouldn't rotate. And esophagus مستقيم, صح? It rotated and went downward into the lung. And if you are careful, there is a pneumothorax. There's extra free air on this side. Okay, because probably it went downward, punctured the esophagus, the bronchus, and punctured through the lung and caused a closed pneumothorax in this area. So excellent job everyone. يلا نرجع بعدين للمحاضرة الأخيرة. يلا too much white. طيب خلينا نحاول نختمها ب20 دقيقة. في couple of questions جتني أو وصلت. طيب كان أحد يسأل يقول لك what is the indication to insert vascular lines? I think this is beyond the scope of this lecture. يعني بقول لك ليش الأسباب بس يعني الأسباب تطول وتطول ما توقف. I would like to يعني give a brief about them. We usually insert vascular lines in a patient when we want to introduce something or want to pull out something. يعني we want to treat the patient with antibiotics, chemotherapy, etc., or dialysis, or if we want to take up blood for evaluations. So this is how we do it. طيب أحد سأل يقول لك إنه someone said okay that's right. طيب في questions كانت هنا. Yeah. Can tube causes emphysema? Yes, they can if they are inserted in the soft tissue skin. So إذا أنت شفت قاعد تدخل في soft tissue, it can cause emphysema. That's a possibility. It's okay to think outside of the box. طيب, what are the four rings in many pictures? ما أعرف صراحة. After inserting any tube or catheter, should inserting any tube or catheter should do an X-ray to locate it. This is actually mandatory to do. You shouldn't do any tube without showing their location. Okay. تمام. This is a part of protocol, by the way. Whenever you are inserting a line or tube, you should always do an X-ray to confirm the location. Let's move on to the last lecture, which is too much white. When we have too much white in our X-ray. So this is the opposite of the other lecture. طيب خلينا نسوي شير نبدأ. بسم الله. بحاول أختم إن شاء الله ب20 دقيقة عشان كلكم ترتاحون مني. يلا. أول حاجة, too much white is basically when we have too much air or fluid. Okay, too much structure occupying the airy stuff in the lung. طيب, وش معناها الكلام؟ معناها إنه if you see this image, it's just diagram عشان أوريكم وش السالفة. So pulmonary edema here. If you see the alveoli, المفروض الألفيولاي تكون black. صح؟ This is a normal alveoli أمورها تمام. معبية هواء وكلها black. However, if I introduce, let's say, infection, which infection can cause edema or bust inside the alveoli, يسمونها alveolar edema. هذه معناها راح تكون whiter. I could introduce pulmonary edema, excess fluid inside the lung. Patient ما يقدر يطلع fluid من جسمه. This is also will cause whiteness inside the lung. ممكن يكون because of masses, mass occupying lesions, structure that grow inside the lung. Mostly cancer will grow inside the lung. It will destroy the air stuff in the lung and then will take up a whitish stuff. The way we translate this, we call this consolidation. It just, or we could say airspace opacity. Airspace should be an airy space. صح? Opacity, it's occupying it. Opacity, opacifying it. Okay, this is how we usually say it. The common causes of pneumonia. There are many common causes of consolidation. Usually pneumonia will usually, there are many causes of pneumonia. It can, you can catch up pneumonia probably if the patient already presenting with signs of symptoms of pneumonia. عنده already infection, علامات infection. عنده حرارة, يسخن, قاعد يكح البيشنت, he's having trouble breathing, etc. هي عليه حرارة. هذا تسوي له WBC يطلع عنده خلايا الدم البيضاء عالية. Probably he has infection in his lung. However, pneumonia in the lung is not that specific. يعني ما أقدر أشوف إكسرا وأقول for sure أبصم عليها إن هذه pneumonia إلا لما أخذ الصورة الكاملة للمريض وأعرف هو ليش جاي الطوارئ أو ليش جاي عندي في العيادة أو ليش جاي عندي في الورد. So this is called, or this is how whitish stuff will present. So أنا أعرف إنه this is black, بعدين هنا كله white, and this is black. And then I'm going through, this is lung, and this is lung. However, all of this is black. And if you see, this is the way the CT will present. It's all of this is black stuff. Sorry, all of this is black, white stuff. Okay. This is called lobar or lobar pneumonia because it takes up a whole lobe of the lung. It doesn't matter what you call it as long as you call it an opacity. This is an opacity. And this opacity is taking up the whole space of the airway and pushing everything around it because this is probably a bus, an infection, and edema. So they take up space. They are not collapsing the lung, they are expanding inside the lung. And because if you think about this inflammatory tissue, so all of the tissue markers, the WBCs, etc., will go there to try to solve it. So all of this will be edematous. Same with when you have an infection around your hand or anything, it's all gonna get edematous. You're all gonna get bigger and more fluid and more cells. So this is how pneumonia would present. So this is called lobar pneumonia. There's another form of pneumonia. So I told you the pneumonia and the X-ray are not that specific. So it could be anything. It depends on the clinical history. If you look at this, can anyone tell me where is the abnormality? If you could catch it, or be more than يعني thank إنه will be more than thankful. I want you to هالمرة instead of telling me this is right or left, I want you to tell me this is right, upper, middle, lower zone, or يعني left, upper, middle, lower zone. Okay, be subjective about this. It's okay. Okay. Excellent, guys. All of you said the right thing. The extra white stuff is in the right middle zone. This patient presented with cough, fever, or he was coughing, let's say, for example, sputum. He probably had a pneumonia in his lung. Okay, that's the importance of doing an X-ray, just to catch these whitish stuff. Okay, move on. And then here is another X-ray. Okay, المرة whiteness, if you could catch it, is in the left side, and it's taking up all of this air, and it's hazy. It's tendamage. It's insinuating inside the left lung. It's not important if you understand this concept. I just want you to catch this is bright and this is white. It shouldn't be whiter, because we know the airway is black, and we see this is whitish. Okay, so this is another example of pneumonia. I will call this a lobar pneumonia because it's taking up a whole loop. Someone else could call just this is a pneumonia, that's it. So here's another example of pneumonia. I think this is a COVID patient. And this is the trick. This, I think you have seen this image in Twitter إلى آخره لما كان وضع pneumonia ووضع COVID pandemic. They used to say about how terrible COVID-19 could damage the lung. This is what it does. It causes a whole whitish lung. فجأة, I lose all of the air inside the lung because all of the alveoli are stuffed with pus and infectious material. And this is what happens. If you look at this, we have the airway in the middle, and then all of this is just losing the darkness of the lung, the air of the lung, because all of this is infected. Okay, so this is another example of pneumonia. So pneumonia can be anything. It all depends on the clinical history. So let's talk about pleural effusion. Do you remember pneumothorax, what we said about pneumothorax? That it is air trapped inside the peritoneal space. How about if we have fluid inside the peritoneal space? Okay, if we have pure fluid, it's not blood, it's not air, pure fluid, which could happen for multiple reasons. But if we have fluid inside the pure space, we call it pleural effusion. Okay, we differentiate them into two types, exudate or exudative or plurulent fluid, but this doesn't matter. This is outside of the scope of this lecture. I just want you to recognize how to catch it. Okay. Like pleural effusion, again, you could look at this and say, okay, شكلها pneumonia. That's correct. You could say شكلها pleural effusion. That's also correct. It is a two differential thing. In reality is we don't usually know the cause until we put the whole image together, or the whole clinical history together. This patient didn't come with cough or fever or anything. This patient had, I don't remember what he had. Let me just remember. Oh, I forgot to put the طيب. I hope I remember the cause. Okay, خليني ألف لكم cause يعني ويكون قريب من reality. This patient had cancer, and he had pleural effusion because of the cancer. So he had it only one side. So it was a cancerous pleural effusion. Okay, just a fluid on the lung, not the other side. It could be infection. It could be infection. Why not? We need to follow this up, do another X-ray, and see exactly what's happening to it. So this is another example. This is a patient who had a heart failure, and he has all of his left lung becoming white. And if you are careful, you don't see any air inside. So probably the pathology is not within the lung. It could be from the excess air outside of the lung, excess fluid outside of the lung. It could be two things. It could be pneumonia, as I said before. So possibility pneumonia is there, and possible perfusion. Patient, let's say he presented with a cardiac failure, and he has excess edema in his body, and he is complaining of a 10-day history of shortness of breath. He cannot take up his breath. And when you do an X-ray, you saw this. This is probably related to his cardiac disease more than infection. If he, another scenario, presented with an acute fever, etc., then this could be an infection. And this is pleural effusion coming from the infection. Right. This is an example of bilateral pleural effusion. We have a bilateral excess fluid. Okay. Why? Because the lung, when you look at it, we see smaller lungs. We see darkness is very small. And we don't see the shadow of the liver, heart is as clear. And we look it down, all of this is whitish. So this is also bilateral pleural effusion. The cause of it depends. It could be a renal failure. It could be anything else. I just want you to recognize this patient has a pleural effusion, and then you add it to whatever he presented with to figure out what's the cause. Okay. Sometimes the way we work up pleural effusion, we might need to aspirate it. ناخذ منه عينة ونتأكد هو إيش بالضبط ونعرف بالضبط وش السالفة. But I want to recognize what is this. Okay. So this is an atypical pleural effusion. Okay. I want you to say what's atypical فيه. ممكن ترجعتين ممكن ترجعتين. Excellent. طيب. So, can anyone tell me what's atypical about this pleural effusion? So if you think about it, يعني خليني أعطيكم هنتات. If you think about it, the pleural effusion usually, okay, is a free fluid. It's a free fluid. يتحرك على كيفه. لما أخلي البيشنت upright, it should all fall downward. زي كل الإكزامبلز وريتكم. Previous example. So تشوفون مسوي leveling صح؟ Leveling. It's caused leveling. يعني level فوق و level تحت. Okay, ماشي صح. أمره تمام. However, in this patient مايل رايح فوق ونازل تحت وقاعد يتحرك على كيفه. It doesn't follow the regulation, doesn't follow the rules حقت الفري fluid. It goes as it's whatever it desires. In this type of patient, I need to think of a differential. في لهم multiple differential ليش المنظر هذا يطلع. But I want to think of one thing, which is empyema. Empyema is just a pus accumulated in the pleural space that is located by a tissue. Okay. إيش معنى empyema؟ إنه ما هو free fluid per se كثر ما إنه collection. كأني أقول abscess بس إنه pleural space. اللي هو في pleural space we call it empyema. We don't call it abscess. You could call it abscess. That's correct ترى صحيح. بس the sophisticated name for it is empyema. If it's inside the lung, it's called an abscess. It's outside the lung, it's called empyema. كيف نعرفه؟ إنه والله البلeural effusion هذا doesn't follow leveling. يعني ما ينزل تحت لما يتحرك. It stays the same طول الوقت. أسوي له اليوم إكسترا البيشنت، ثاني يوم أسوي له إكسترا، ثالث يوم أسوي له إكسترا، نفس المنظر. This is you could consider empyema. The way to diagnose it تسوي له CT scan وتشوف شو السالفة. With contrast طبعا عشان تشوف الوضع. ما علينا. هذا extra information just for you. Just recognize this is not a regular pleural effusion. ممكن يكون other causes، ممكن other causes، بس ما راح أشرحها كثير، أدخل فيها لأنها معقدة شوي. طيب. Another thing I wanted to teach you because I learned the hard way. This is differential for white stuff in the lung. So anyone can tell me what is this or where is the abnormality? Again, use the zonal stuff. Tell me which zone it is. Right lung, infiltrative, excellent. Okay, right lower lung, excellent. Excellent job. You are talking about the right lower, which is this area. It's whitish. Here is whitish. Excellent job. Okay. First instinct, I would think this is probably infection. Okay. So, the physician called me and he said, no, I don't think this is infection. I told him, why? Why is this not infection? He told me the patient didn't come with fever. He wasn't coughing. He was actually very good. And he suddenly had chest pain. I was like, sudden pain, and he has this whitish stuff at the periphery of the lung. That's weird. And he doesn't have symptoms of pneumonia. He said, no, doctor, he doesn't have any symptoms of pneumonia. He doesn't have any symptoms of infection. So, and he said the name of the sign here. So what is this sign? What is this appearance? This is called could be chronic, okay. This could be, so someone said chronic bronchitis. Bronchitis will come with the symptoms of bronchus inflammation. Okay. طيب. خلينا نكمل. So this is a whitish thing at the periphery of the lung that is at the periphery. It is, by the way, causing small perfusion and it's obscuring the cospheric angle. I agree with that. This is called the Hampton hump sign, which is a sign of pulmonary embolism. Okay, it's a dome shade pleural-based opacification. تيجي الناس اللي عندهم انه pulmonary embolism. ايش معنى pulmonary embolism؟ انه البيشنت كان عنده clot، يعني كانه ischemic او كانه يعني clot قفل على واحد من major arteries حقت اللنج، صار infarction وقتل لي الخلايا اللي تدخل الهواء في اللنج. What happens? This is all killed cells. This is a lung infarct. اللنج هنا ماتت شوي. ليش؟ لأنه كان في pulmonary embolism قفل عليها الارتري أو قفل عليها blood supply. And the way they present usually في الإكس-راي إنه يكون عندهم whitish stuff at the periphery without history of infection. يجيك البيشنت ما عنده history of infection. He just have a whitish stuff at his base, at pleural space. That's usually because of infarction. This is an example, by the way. Okay. So this is how pulmonary embolism إنه يصير عندي clogged one of the arteries قفلناه، قطعنا ال blood supply here، واللي حصل إنه this is become infarcted dead tissue. فdead tissue معناه أنا قتلت الألفيولاي فقط، فهي لما تموت الخلية تطلع لي المحتوى حقها ونحاول إحنا نحاول نحافظ عليه نسوي إديمة المكان فيصير بوايتش، يصير أبيض. بس اعرفوا لو patient جالكم في أي يوم من حياتكم okay يشتكي من acute chest pain سويتوا X-ray طلعت فيها white stuff but he doesn't have any symptoms of infection, please consider إنه تكون pulmonary embolism. The way you should work it out إنه على ال Wills criteria وتعرفون high risk patient whatever، هذه بعدين تعرفونها مو لازم الآن، بس there is a workup for pulmonary embolism. بس اعرفوا إنه ممكن كل white pneumonia it could be an infarct. okay. طيب آخر شيء بتكلم عنه pulmonary edema which is very hard concept to understand، بس يعرفوا إنه أحياناً يصير عند البيشنت excess fluid في اللنج يتوزع برا الانستيشن حق اللنج، يعني يصير أعبي الأيرفيولاي حقت اللنج بفلويد. okay bilateral. The way it looks like usually على الإكس-راي no symmetrical bilateral. إذا هو symmetrical bilateral فما probably this is pulmonary edema ما هو something else. Is this could be infection? Could be an infection. ليش لا؟ بس يعتمد على الهيستوري البيشنت جايب إيش. okay. طيب this is an example also pulmonary edema إنه كل هاللنج صارت whitish. تقولي طيب ممكن هذا infection؟ ممكن يس ممكن infection يعتمد هل ال WBC عنده high، هل هو infected status، هل هو septic shock إلى آخره، بقول عنه infection. If not then probably this pulmonary edema. If he's a cardiac failure مثلا ولا عنده مشكلة في الكدني وما يقدر يطلع الفلويد حقته إلى آخره أو be considering pulmonary edema. okay. This is another example of a cardiogenic pulmonary edema يعني الكاز جاي من الكاردياك. It has a distinctive feature إنه يكون عندهم الفلويد جاي على فوق جاي من السنتر، لأن الكاردياك في السنتر صح فيجيهم فلويد على السنتر because of the increased pressure داخل الهارت. So basically this is a common X-ray you're going to encounter in any cardiac patient. يجيكم known cardiac ويصير عنده pulmonary edema in his lungs. This is another cardiogenic pulmonary edema إنه large heart very large heart ويجيكم fluid bilateral. هنا تشوفون هي pleural fusion فممكن pulmonary edema يجي معاها pleural fusion. Very common. It's not strange. تخيلوا الإديمة زادت قامت تتكاثر قامت نزلت تحت على pleural space. It's a common concept. It's not that strange by the way. في something they always say I'm gonna دائما يتكلمون عنه في المحاضرات الأخيرة ويتفلسفون عليكم عليه. I'm gonna say it just for the sake of you learning it from my lecture. إنه في حاجة اسمها Kerley line which is when the fluid accumulate in the interstitial space على شكل كأنه leveling يعني خطوط. شوف الخطوط هذه اسمها Kerley lines. هذه معناها إن البيشنت عنده pulmonary edema. Could it be other causes؟ ممكن other causes بس mostly بتقول عنها pulmonary edema and then we figure out what's the cause of pulmonary edema later on. فيقول لك إنه heart failure can have different appearance نفس الشيء. It can have a Kerley lines which is the early phase and then it can have pleural fusion which is the late phase. يعني ممكن those fine lines accumulate وتخلي لك pleural fusion. Okay. طيب. I'm done with this. I'm gonna answer a couple of questions قبل ما ننتقل للكل. Okay. طيب. في أحد قال which excellent. أحد قال إنه ممكن البي إي مو باين دائما في الإكس راي. That's a good example. Yes, X-ray is not the modality to diagnose PE ترى. PE أو pulmonary embolism ما يبان ترى بالإكس راي إلا في 20% من الأشخاص، خاصة الأشخاص اللي لهم فترة جتهم الأمبوليس وقفل لهم الآرتري وصار عندهم dead tissue. That doesn't happen all patient ترى. يعني ممكن يقفل لهم الآرتري بس ما يصير dead tissue ترى عادي. It's only happened 20%. But still, if the suspicion is high in this PE, you should go for the modality of choice, which is the CT scan PE protocol, not an X-ray. Just an X-ray يمكن يطلع له other cause. يمكن يطلع عند patient heart disease. يمكن يطلع عنده pneumonia, bilateral patchopathies يعني. It's okay. طيب أحد كتبت I'm not sure what that means. طيب هنا خلينا نشوف الإكس-راي ال questions. طيب حلو السؤال. طيب can COVID pneumonia be confused with pure fusion? Yes, it can be. ترى عادي جدا. Again, when you see an X-ray, you need to interpret it in the base of the patient. If the patient going with infection, you should say this is an infection. He's going with edema, شكله مرة مليان fluid. The patient he's overpowered by fluid, then you should interpret it as fluid. But then how to differentiate between perfusion and pneumothorax? Again, it's related to history. Okay, pneumothorax يجيك البيشنت injured. Okay, as one clue. اثنين، هي لما تقيس له البلد مثلا هيموغلوبين تلقاه قاعد ينزل معاه، فجأة يقول لك dropping hemoglobin, dropping on its level. Then it gives you that he's losing blood بس not sure where. واشوف اللنج اشوفها قلبت وايت، قبل كم يوم كانت سوداء، فجأة قلبت ابيض. ليش؟ هو شكله عنده pneumothorax. It goes with the history أكثر. But again, when you look at whitish and blackish, look at it with a history معه. هذا ال R1 R4 بشوف إذا بدأنا اليوم إن شاء الله. يعني خلينا ناخذ الكويز وبعدين نشوف. عندي 2 questions last أو عندي سؤالين بس إن شاء الله. خلينا نشوفهم. جفت شوي أسفة. طيب. So we have the X-ray أول واحدة. Activate. يلا. What is the abnormality? خليني أوريكم السكرين حقتي تشوفون شو السالفة. الكول كيف يطلع لي. Okay. I like how there's discrepancy in the reporting. And this is what happens ترى usually. إن نشوف X-ray إحنا نحتار. مش ممكن تكون is this or this is that. Which I like that. That means إنه you are thinking, you are being critiquing about the X-ray. Okay. So خلينا نشوف X-ray ونحاول نجاوب قدر الإمكان. So I'm looking at the X-ray, I'm reading the airway, بنشوف اللانجز. وأشوف اللانجز هنا في extra whitish here. whitish هذا ماخذ كل lower zone of the lung. Okay. If I tell you this patient presented with the fever إلى آخره بتقول pneumonia, which is the correct answer in this case. However, if I tell you this is the patient who comes with sudden pain where he doesn't have any symptoms of pneumonia, and I showed you this could be pulmonary embolism أو which. Pulmonary embolism usually at the periphery, فهنا بتكون سبيد المنطقة هذه يعني بتكون هي blackish, but this is a possibility تكون this is pulmonary embolism. That's okay. This is a possibility. And then pulmonary edema, ممكن يكون pulmonary edema, localized pulmonary edema is a possibility. في certain pathology can cause this, however, it's very less likely, but this is a possibility. We usually go with common is common. So probably in this X-ray, the commonest cause is usually pneumonia, infection. Okay, good job. يلا بوريكم السؤال الأخير. يلا وروا إجاباتكم. What is your suspicion? شو أنا ما قلت لكم diagnosis، أنا قلت لكم suspicion. أنا أعتقد إنه كل الناس مختلفين. Okay, that's cool. Like the poll again مختلف. كل واحد يجاوب بطريقته الخاصة. Excellent job. والله good response. Nice guys. طيب خلينا نشوف الإكس راي، نوريكم إياها ونناقشها. أعتذر إنه طولنا على الوقت، بس I hope إنه أنتم قاعد تتعلمون قاعد تستفيدون. يلا. So see the poll here. poll مختلف. في نصكم قاعد يقول pneumoedema والنص الثاني قاعد يقول pneumoperitoneum, which is both correct ترى. Probably he has both. ممكن واحد منهم، ممكن اثنيناتهم. بس صدفت in this case the patient had pulmonary emphysema إنه collection بس accumulating dislocation. Okay. This could be pulmonary edema. ممكن ترى. ليش لا؟ وارد. كيف نتأكد إحنا؟ كيف إنه نشوف الهيستوري. والله patient كان عنده infection. As in this case, he has bilateral opacities. له infection الحين في الطوارئ ولا في ICU for 10 days. Okay? And he's not improving. After antibiotics, he's not improving. شفت الإكس راي حقته وهو okay. I think this is not a simple infection. I think this is complicated by empyema. يعني collection or abscesses in the pleural space. How to confirm? do a CT scan وتأكدون إنه أمور البيشنت تمام. Otherwise يعني إذا هو acute patient وتو له كم يوم في الطوارئ this could be pulmonary edema. الإديمة ترى تأخذ وقت قصير عشان تتكون، بس empyema it takes a longer time. Okay, I hope you guys enjoyed the presentation and the lecture. I hope I was helpful and useful. أعتذر على التقصير. I'm sure إنه this is not up to the standard of lectures that you are used to. اعذروني ما حصل لي وقت مرة طويل عشان أقدر أحضر، بس I hope you all enjoyed this. Thank you so much for your participation. I hope we meet in better light. I got it. Yeah. في أسئلة أنا آسفة. نسيت الأسئلة. طيب. طيب. خلينا نشوف الأسئلة بس. في أحد سأل can we get the slide please? Yes, I already sent the slide to you guys.
Thank you, Dr. Arwa. It was a very clear and informative lecture. This is the end of Basics in Internal Medicine course. Thank you all for attending, and we hope you enjoyed this clinical course. We would highly appreciate your feedback and hope to see you again in future courses, inshallah. Thank you.
Thank you, guys.